Across the globe, primary healthcare infrastructure is buckling under the pressure of a rapidly aging population. Clinics are over capacity, and the traditional model of in-person, continuous care for chronic conditions is becoming mathematically unsustainable. We can see this acute pressure in Thailand, where roughly 18% of the population is over 60. Regions like Nakhon Ratchasima are currently facing extreme bottlenecks in their primary care networks. The mandated policy solution to this crisis is telehealth. By moving routine checkups and monitoring online, healthcare systems aim to reduce hospital crowding and maintain continuous care without requiring physical travel. Yet, despite aggressive government mandates and investments in health tech platforms, telehealth deployment is stalling at the local primary care level. When investigating why this adoption fails, tech developers and policymakers consistently focus on the same assumption. Elderly patients lack the digital literacy to participate in remote care. If this assumption is accurate, scaling telehealth for an aging demographic is impossible, but the data suggests that the industry is overlooking the actual variable causing the friction. This research paper, published in 2026 by a team at Srinakhon University, maps the readiness of telehealth services across 19 subdistricts in Nakhon Ratchasima. The researchers used a purposive sample of 38 participants, carefully dividing the group perfectly in half, 19 primary healthcare providers and 19 elderly residents. This dual-sided survey structure provides a distinct methodological advantage. It allows us to simultaneously audit the supply side, the clinics, and the demand side, the patients, to locate the exact point of failure. The empirical data challenges the tech illiteracy myth. The primary bottleneck preventing telehealth adoption is not the elderly user's inability to operate a smartphone. The actual barriers identified are a structural deficit within the provider infrastructure and a significant lack of patient trust regarding data privacy. Framing elderly patients as tech-illiterate liabilities actively diverts critical funding away from these documented systemic failures. To understand this, we start on the demand side, analyzing the responses from the 19 elderly patients surveyed. The tech industry designs telehealth platforms under the baseline expectation that seniors cannot independently navigate modern digital tools or manage their own routines. This table directly measures the physical health and independent living capabilities of that demographic group. Look at the metrics for feeding oneself and moving independently within a residence. These capabilities score high, with mean averages well over 4.0. These individuals are highly autonomous. That autonomy translates to their technology usage. The elderly respondents recorded a proficiency in mobile phone usage at a high 3.79 out of 5. Furthermore, their satisfaction with using technology for enhanced service convenience scored a 3.95. They clearly recognize the utility of digital tools and actively express a desire for the convenience they offer. The data does show a moderate score of 3.18 for traditional computer usage. However, smartphones, not desktop computers, are the primary hardware vector for modern telehealth applications. The elderly possess the baseline technical requirements and the willingness to engage with remote care. Patient capability is not the root cause of the system's failure. If the demand side is ready, we pivot our analysis to the supply side, the medical personnel at the primary care level. The survey uncovers a stark operational reality. Over 50% of the surveyed medical personnel have not implemented telehealth in any capacity. This table tracking the telemedicine services of medical personnel explains exactly why deployment has stalled. Notice the moderate to low scores for basic systemic needs. Equipment procurement sits at 2.89, and professional training for telehealth utilization scored a 2.67. Behavioral science provides a framework for this, called the Unified Theory of Acceptance and Use of Technology, or UTAUT. In this model, hardware and staff training represent facilitating conditions. When those drop, the system fractures, cutting off the path to adoption. If a local clinic lacks bandwidth, lacks diagnostic tools, and trained staff, to connect with patients, the user's digital literacy becomes completely irrelevant. Telehealth adoption is currently blocked by structural and funding deficits at the primary care level. Even if the clinics were fully equipped tomorrow, a second massive barrier would immediately block adoption. We have to examine this data table detailing what the elderly actually expect and fear regarding remote services. The baseline demand is real. Their expectation for continuous healthcare after using telehealth scores a high 3.75. But item 3 reveals a psychological flaw in the system, their confidence in the security of their personal data. That metric sits at a 2.25. It is categorized strictly as low, representing the worst scoring metric in the entire study. We can map this using the technology acceptance model. Adoption requires balancing positive utility against negative friction. The high perceived ease of use generated by their smartphone proficiency is neutralized by the weight of perceived risk. Seniors are highly anxious about exactly what happens to their private medical history once it is transmitted to the cloud. This anxiety is compounded by concerns over the clarity of remote communication. They hesitate to share vital, sensitive health information if they suspect the connection is either insecure or inaccurate. High technical proficiency offers limited value without transparent data privacy guarantees. This study suggests that seniors will forego the convenience of telehealth if the system feels insecure. So, how must policymakers and developers pivot to fix this broken ecosystem? On the provider side, capital must be reallocated away from basic pilot testing and into permanent infrastructure. Those investments must deliver diagnostic hardware to local clinics, coupled with targeted, ongoing digital capacity building for the medical staff. On the patient side, tech developers must move beyond UI simplification, like making app buttons larger, as the primary fix for senior telehealth. Developers must build stringent data security protocols and design interfaces that clearly communicate those protections to the patient. A functional telehealth network requires bridging both the physical hardware gap at the clinic and the psychological trust gap with the patient. Fixing these specific structural and psychological bottlenecks has implications far beyond a single district in Thailand. Realizing a scalable telehealth model maps directly onto the United Nations Sustainable Development Goals. By securing uninterrupted care for an aging population, healthcare networks actively serve SDG 3, good health and well-being. By eliminating geographic and mobility barriers, this framework fulfills SDG 10, reduced inequalities, granting rural seniors the same access as urban populations. The Nakhon Ratchasima data reveals that low digital health integration stems from gaps in systemic support and security. True active aging will only be achieved when the health tech industry stops treating the elderly as liabilities and starts designing for capable participants who demand systemic security.